Okay, great. Hi, everybody. I think we'll begin. Hopefully, we'll have a few more people join us in the coming minutes. But thank you so much for joining our discussion today on violence and threats against healthcare during COVID-19. My name is Rebecca Root. I am a reporter and journalist with DevEx. For those of you who don't know who DevEx is, we are the media platform for the aid and development community. And I'm really delighted today to be working with our panelists to host, hopefully, what's going to be a really exciting and useful and compelling conversation. Our event today is going to be around an hour long. We have 5 amazing panelists joining us today, and I'll quickly run through their names for you so you know who we've got coming. We've got Christina Villa, Managing Director of Insecurity Insight and the Aid in Danger Project. We've got Len Rubenstein, Chair of the Safeguarding Health in Conflict Coalition. Erica Burton, Senior Advisor of Nursing and Health Policy at the International Council of Nurses. We have George Thomas, Chief Orthopedic Surgeon at St. Isabel's Hospital in India, and we have Aline Salgado, a nurse based in Mexico. And we will have some time at the end for questions. So if you have one for all of our panelists, for just one of them, do feel free to put it in the chat box at the side, and we'll do our very best to get to it at the end. If you have to duck out, don't worry too much. This session is being recorded, and shortly after, we will send you a link so that you're able to play back. And finally, if you would like to join our conversation on social media, then we definitely encourage you to do so. We are on Twitter at SafeguardingHC and also at Insecurity Insig. So that's INSIG at the end of that, the end of the word insecurity. Great. So I guess we can dive right in. And the question I was asking myself today earlier when I was preparing for our discussion was, violence and threats against healthcare during COVID-19. I was thinking, isn't it crazy that we have to even have this conversation? Because surely everybody has the right to go to work, do their job, feel safe in their workplace, and return home safely. But at DevEx, health worker safety in particular is something that we've been covering for quite a while now. And typically we've looked at that through the lens of occupational hazards, perhaps needle stick injuries or something related to the workplace. And then obviously the dangers of being a healthcare worker in areas of conflict. But recently, well, specifically throughout the last year, there have been more and more organizations that have come to us, and I'm sure gone to others and said, hey, we're seeing a real increase in the amount of threats, intimidation, attacks against our healthcare workers, our facilities, the transport that we're using. And it seems that the fear and stigma brought on around COVID-19 has really led to an increase in some of this real feeling of unsafety and oftentimes very, very real threats and horrible incidents that I'm sure many of you have heard about. But I guess what we've kind of been lacking really is kind of that hard-hitting data. But today, a new interactive map has been launched. It was developed by Insecurity Insight with support from Map Action and also the Safeguarding Health in Conflict Coalition. And this is really providing data on how many attacks, threats, intimidation efforts there were towards healthcare workers, but also transport, the facilities that they work in last year during 2020. So that total that it's got at the moment is 1,172 incidents. But of course, they're only the ones that have been reported. There must be many others that haven't been reported. And this interactive map, it allows you to kind of look at, okay, how many of these incidents were related to ongoing conflict, but how many of these were also related to COVID-19, and where in the world might there be more attacks or less attacks, and where is it really the most dangerous right now to be a frontline healthcare worker? But somebody who can articulate more about the map and in a far better way than I can is Christina. So I would like to invite Christina into the conversation to tell us a bit more about the map and how it might be used as a tool to help us in safeguarding healthcare workers in the facilities they work in. Christina.
Thank you, Rebecca, and thank you to everyone who's joined us today. I look forward to sharing with you this interactive map, which I hope will be a useful tool that you can use in the future. But before we get to the nitty-gritty of it, let me just tell you in a few words of how this map came about. It was about a year ago, when nearly the whole world was sent into lockdown, that my team, who monitors attacks on violence against healthcare on a daily basis, suddenly reported that something was going on. Instead of discovering the 1 or 2 events that we normally find every day, there were suddenly 5. 6, 10, 15. It was really like as if we were flooded by violence against healthcare. And there was something else that we noticed. While we had always focused on violence against healthcare in conflict, and this kind of violence by definition is perpetrated by conflict parties, we suddenly saw that here something very different was happening. The perpetrators were community members, family members, even patients or protesters against public health measures. So we were actually looking at a very different form of violence. And as I said, the events were just coming in, and we were extremely grateful when we received support from Johns Hopkins and Drexel universities in coding. And it was by around August that we felt we'd finally got on top of with this flood of events coming in to sort of categorize them and look at them more systematically. But then we were faced with this complicated question. Well, how can we communicate what we feel is going on here with the wider world? And that's when I turned to Map Action, the mapping charity, and explained what we had and said, can you help? And what I'm going to show you in a minute is the result of the technical collaboration between Insecurity Insight and some fantastic volunteers from Map Action. And what you will see on this map is the data that has been compiled by the Insecurity Insight team monitoring the events, with data taken from the World Health Organization surveillance system on attacks on healthcare, and many contributions from other safeguarding health in conflict members, including Physicians for Human Rights, IntraHealth, Medical Aid for Palestinians, and also a survey carried out by the International Council of Nurses. So without further ado, let me see that I can get this into screen sharing mode and that I can actually show you the tool. Can everyone see this? Well, I suppose I can't hear you, so I assume you can. If not, please put something in the chat. So what you see, here is this map, and you'll have a number of events appearing here. And what we're going to do as a first thing is we're setting it to last year. We're updating this map all the time, and that's the idea, that you can use that as a tool to keep looking at what is happening. And the events are usually about sort of 6 weeks after they've happened. So we've set it now to 2020. And as you can see here, you can look at the world through 3 different lenses. You can look at all the countries where there was violence against healthcare as defined by the WHO as any violence or threat of violence that interferes with the delivery of healthcare. You can also look at through the lens of conflict. And then you suddenly see very different countries shining bright red here. Or you can look at the world through the lens of COVID-triggered violence against healthcare. And here we suddenly see, again, very different countries coming up, and in particular, Mexico and India. And these are 2 countries that have not really been on our radar as places that are particularly affected by violence against healthcare. And I'm going to show you now a few ways in which you can use this data. So you can click on a country, and then to your right, a summary of the country pops up. And as you can see here for Mexico, we've included the information on the perpetrators, and the majority are protesters. And while we don't know what weapon they used, many may have used just fists, the single item that gets the highest counts are liquids. We're talking hot coffee, bleach, household items. However, if we are now switching to the conflict view for the same country, we suddenly see a very different perpetrator. They're generically referred to as non-state actors, but in the case of Mexico, we're talking about criminal drug gangs that are involved in territorial conflicts that cause more than 15 violent deaths a year. And their weapon? Firearms. So this just gives you an idea of how we've set up this map, that you can look at different countries and through the lens of different forms of violence against healthcare, and it should give you an idea of what is going on. So in case you're excellent at mental arithmetics, you may have worked out that the sum of conflict and COVID-related events does not necessarily total up to the total events. And this is because an event can be both. Because the way we've defined a COVID-related event of violence against healthcare, we're looking both at what triggered the violence, opposition to the health measures or attacking health workers on their way to work during lockdown. But we're also looking at the impact the violence had, and if conflict-related violence affected the delivery of the COVID response, then a conflict event is also considered a COVID event. And let's have a quick look at Libya here, clearly a country highly affected by conflict violence. But if we go to the COVID view, we see that there are fewer events, and these are all events where conflict affected the delivery of the COVID response. And as you zoom in, as I've just done here, you can actually click on these little squares and the event description comes up. Now, you probably don't have to be very good at maths to see that the 4 events listed here doesn't correspond to the 3 squares on the Libya map. And that is because the map consists of or uses 2 different ways of counting. We record whenever an event has been reported for a country, and that's included in the counts for the country. It only appears at a little square on the map when it is geocoded. And not all events are geocoded. And there are 3 different reasons. It may be because we simply haven't got round to it. And if you look at the January and February events, you might find that there's few yellow squares. But if you come back in 3 weeks' time, I hope you find many more. Another reason can be that there are reasons to protect the person who or the group that provided the information, and that we do not want to show the location or the detailed description of the event. Another reason is that, as I mentioned earlier, I'm trying to move this map at the same time, that we also want to include all available information. And this depends that for different countries, we have different access to information. So if we look at Afghanistan, then the total number of events you can see is extremely high, but the number of yellow dots is not very many. And this is also, as you see here, when we look at the perpetrators, there's no information, and we also don't know the weapon. And that is that for a country like Afghanistan, we depend very much on the health cluster and the surveillance system from the WHO to populate this, because they are very, very active in monitoring this. But they don't supply that kind of information. So therefore, it is missing in this case on the map. So this little run through is meant as a little health warning, because as you use this map, it is meant for you to compare countries, but at the same time, care needs to be taken, because in each country, there are multiple factors that influence whether the events are reported, whether the events are amplified or pass through mechanisms, and that's all influences to what extent this information gets added to this map. The other thing I wanted to mention here is that as you click on any of these little squares and you get the event description, you also have a number. And should you ever have any questions, don't hesitate to get in touch. You can ask about specific events or particular countries, and we're very happy to share with you what we know about the incidents. You can also download the data from the Humanitarian Data Exchange, and I believe the link will be put in the chat. And yeah, we very much look forward to an interaction with everyone on this map, and do come back in the future to see how it's updating. I will pass on in a minute to my colleague panelists, and some of them will really talk of what it's like to be a frontline health worker. But before I do that, I wanted to close with the 3 reasons of why we have done this map. The first is that 2020 was a very unusual year, and we wanted to have a way of sharing with a wider public just how much violence against healthcare spread beyond the countries we had all focused on in the past. The second reason why we wanted to do this map is that we feel we need to think about the perpetrators of this violence, because only if we know who is doing it and possibly how and why can we think of strategies to address it. And the final reason is really the big motivating factor, because there is far too much violence against health workers at the front line, and this impacts the delivery of health response in conflict and during pandemics. And we very much hope that this map will be an interactive tool to which people will return to keep themselves informed just how widespread this problem is, and to get us all thinking of what we can actually do to address it. So thank you very much for being here, and I'll pass back to Rebecca.
Great. Thank you so much, Christina. And for anybody wondering, the link to the map is in the chat box. There's also an email address there. So if you do have any specific questions for Christina and her team, feel free to drop them an email, but also feel free to put them in our chat box as well. And we'll do our best to make sure to try and get through some of them at the end of our conversation. But now I do want to turn to Erica. And I'm guessing that in your role, you've heard about a lot of the incidents that, that Christina mentioned. You've probably heard many similar incidents. And so I want to ask you what you think the reasons are behind these kinds of incidents, and what the lasting impact or damage really is on the health workforce.
Thank you so much, Rebecca. I just want to thank the coalition and all of the members for this work. ICN is so committed to this work, and being a part of the Safeguarding Health in Conflict Coalition has allowed us to really focus on this issue. Insecurity Insight has done an excellent job in the data collection, analysis, and reporting through this map. So I just want to acknowledge that. I do want to take a closer look at what this data actually means for frontline health workers, what it means for the lives of health workers, the lives of their patients, and the lives and really the health of our world. Since the start of the pandemic, ICN has heard of reports of incidents of violence aimed at nurses and other healthcare workers. They've been ostracized, they've been threatened, they've been attacked. And now with the work of Insecurity Insight and monitoring these, plus reports from our national nursing associations and other reports around the world, we've been able to really map these and look at this visually to show the true extent, as Christina has just mentioned. We've mapped now at least 412 incidents that are directly related to COVID-19. And we do know that this is probably an underestimate considering the lack of reporting that does happen when it relates to violence and abuse against the healthcare workforce. Healthcare workers have been working diligently now for over a year as the pandemic started, end of December, early January in some countries. We're caring for our communities when we need them, when they need us the most. And as Rebecca said, it's absurd to think that we're having this conversation about during a time when we are needed the most and we are putting our lives at risk, that we are having to talk about being victims of violence and abuse. So as outlined in the report that was published today, along with the map, which I think is going into the chat box as well, some common triggers were noted in the reporting, and many were related to opposing of health measures, so like testing for COVID-19, quarantining for COVID-19, and many were also related to this fear that health workers are transmitting the virus and that they're the carriers of the virus. Health workers are also experiencing violence and abuse while traveling to and from work, so either walking or on the bus, which we'll hear a little bit about from a frontline health worker just shortly after. They're wearing their work clothes, so they are identified as healthcare workers, and sort of this is how the violence begins. In some countries, healthcare workers have been threatened, they've been suspended, and they've been fired or even arrested for speaking out about the difficulties that they're experiencing at work. And so while we want to understand these triggers for prevention efforts, we also really need to be looking at the root causes that are factors that are typically not related to the perpetrator or the victim, and that are more structural, bigger structural problems that are rooted in social, economic, organization, and culture. And so I just want to briefly touch on some of these bigger structural issues that I think we need to move our focus to if we really want to prevent this issue. The majority of healthcare workers we know are women, and discrimination and gender inequality contribute to these incidents of violence. This then further impedes or contributes to our work to achieve gender equality and the empowerment of women. If women are the victims of gender-based violence, that just then repeats this cycle of violence and of disempowerment. Right now, the world is also experiencing an infodemic. And so the WHO has called an infodemic or described it as an overabundance of information, both online and offline. And so we're seeing that this infodemic is leading to misinformation and disinformation, which is then undermining the public health response and polarizing the public debate on topics related to COVID-19. So we see these like very polar opinions on things that should be really evidence-based and fact-based. And so this starts to fuel stigma, it starts to fuel discrimination, it makes people uncertain, it adds to mistrust and fear. And so if you think about that going on, people are also experiencing this collective grief. They're experiencing anxiety, we're isolated, we're under immense economic stress. And so all of these things are coming together in this perfect storm. And part of the solution definitely lies in addressing these issues that then create the triggers. Such as fearful that that nurses and doctors and healthcare workers are spreading or the virus, or that it's being passed in an ambulance that's parked in front of your house, which are some of the reports that we have received. At the end of the day, the violence is absolutely unacceptable, and it hurts everyone. It hurts health workers, it hurts patients, it hurts families, it hurts communities, and it ultimately hurts the health of populations. But this is not new. When we're looking specifically at the nursing profession, the ILO, International Labor Organization, considers nurses actually to be at extremely high risk of workplace violence. And nursing has been called one of the most dangerous professions. So this is unfortunately the reality that nurses and healthcare workers face. Over the last year, we have then been put in even higher risk situations where we're facing, and we continue to face, difficult working conditions. We don't have a lot of safety mechanisms in place in many countries. We're dealing with insufficient and inadequate protective equipment, or PPE. We have increased working hours. We have huge workloads. We have these unprecedented demands to deliver patient care. And we're doing all of this without protection. We know that hundreds of thousands of healthcare workers have been infected, and thousands at least have lost their lives. The International Council of Nurses did a recent study that showed extremely high numbers of infections in nurses. And so we estimate that around 10% of infections are in health workers. So that puts the numbers in the millions. So on top of all this, we have fear and we have actual violence and abuse that is further exacerbating this psychological and this physical impact that healthcare workers are feeling during this really difficult time. ICN has looked at what we're calling the COVID-19 effect, specifically in nurses, that we are experiencing mass traumatization, which we suggest is this unique and complex form of trauma. And so the longer term effects of this are extremely concerning. We already see extremely high numbers of post-traumatic stress disorder, of anxiety, of depression, and this COVID-19 effect will likely continue to increase these issues. On top of the consequences to individuals is also that this violence and this mass traumatization has the potential to devastate the entire health workforce. It leads to increased absenteeism, we know, attrition, and quite high and concerning rates of intention to leave one's profession. So we've had reports of countries, our national nursing associations, reporting that nurses are saying, look, this feels too unsafe. I'm anxious. I'm depressed. I no longer want to work in this profession. And so for the nursing workforce and for the healthcare workforce in its entirety, we are heading towards massive deficits. For nurses, we already were looking at a 10 million deficit, and the COVID-19 has the potential to increase this number to almost half of the current nursing workforce, which is around 14 million or so. With these deficits, healthcare systems will just not be able to meet population health needs. And so while violence and abuse is a reality, it's not part of the job, and it must not be accepted as such. These are violations of human rights, and we have to act swiftly and intentionally to protect our health workers and our health systems. Thank you so much for participating, and we will talk about later on some of the recommendations that we have that can address some of these concerns.
Great, thank you, Erica, and thank you for also highlighting that it isn't just an issue during 2020 and the pandemic, but that nurses in particular are always kind of doing one of the most dangerous jobs. I think that's really important to bear in mind as we think about, as you say, some recommendations on how to tackle this. But George, I want to come to you as a frontline healthcare worker in India. I want to hear more about your experiences.
Okay. In India, there is always a low level of violence against healthcare personnel. In the early days of the COVID pandemic, after the Indian government announced a sudden and very severe lockdown from March 25th, in the early months, the map must have probably made in the early months, because there were a significant number of events that occurred due to this sudden lockdown and the fear which was engendered by the World Health Organization advice to test and trace. So most of these events which have been marked on the map occurred when the healthcare workers were attempting to trace contacts of people who had been found to be infected. This was in the early days of the pandemic in India, where even people with no symptoms, asymptomatic, if they were found to have been infected by the RT-PCR, they were being isolated, not in hospitals, but in various kinds of buildings which are not really hospitals, because the asymptomatic, there was a rough classification. The asymptomatics and mildly symptomatic, they were in places which are not hospitals, and only those who were severely ill were admitted in hospitals. And we must remember that in India, 70% of beds in hospitals and 70% of healthcare workers are on the private sector. Doctors are in the private sector. The private sector was completely shut down for 3 months, from March, April, and May, and was only allowed to slowly open slowly in May and then June, and now it's completely open. So during this time, the fear engendered in the general population, I would say it was not entirely misinformation, because in the early days, everybody was told that this disease can spread through the air, it can spread by aerosol, it can spread by touch, by fomites. So there was fear among the public that this was a terrible disease which could kill you easily. And this probably led to when the healthcare workers went to trace those who were mildly ill, well, they were resisted. And that's what most of those yellow dots are. Now, in India, you would find that nurses are very seldom attacked. It is usually doctors who are attacked because of the loss of a patient or perceived negligence on the part of the relations of the patient. So the background violence is usually directed against doctors, and very, very seldom are nurses attacked. So I was interested to hear Erica say that they are most vulnerable, maybe in other parts of the world. It's not true in India, but it was true during COVID. And beyond the nurses, we have a category called the ASHA, and they are not fully trained nurses, but one step below. And they do the contact outreach services in the community. They are present all over in the villages of India. And they were the most vulnerable during this COVID. But I would say that from September to now, these incidents of violence, low-level violence, have decreased remarkably, and we're probably back to pre-COVID time. So this is my understanding of the situation in India. Thank you.
Great. Thank you, George, for sharing your experience. And Eileen, I want to come to you and hear about whether your experience in Mexico has been different or similar to that of George's.
Hi, everyone. Well, the experience here in Mexico is very similar to the India. The health personnel is being attacked since a year ago now, and many different ways. We saw the map from Christina. Is a very interesting map. I really impressed. But I'd like to share another way to aggressions here in Mexico. Christina said a moment ago, who is making this kind of damage? But I really like to share the feeling about these situations here in Mexico. Who is not making anything? Who's not making something to help the health personnel in this kind of situations? These situations was just not an aggressive physical situation, mental, emotional. Everything is really hard. It's really difficult here in Mexico. Notice just the attacks for the people who is our people, and look at us in the streets and send us chlorine, coffee, injuries, aggressions, physical aggressions. It's not just the people who is making this, it's also who is not making something to avoid this kind of situations. It's really painful to see that even one of us is not having the resources to be attending when we are sick or our family was sick. We must to be conscious of this kind of passive aggressions. These passive aggressions when we are not able to attend our people, even our family. We must to go out of the streets to trying to get some oxygen, tanks of oxygen. And in the past days, we have a lot of we have not oxygens. There were lines in the streets, in the places of distribution of this material to can help our people. It's not about only these things. It's about the difficulty to get help from even our workplaces. in our workplaces, in the way, in the place where we are having the half of our lives, and so many people, their lives itself. And it was really sad, and it was really difficult to know that the government, that the authorities are not making enough to end this kind of situation. The people is not having the precautions to get out of the streets. Seems like it doesn't care at all. And we are having this emotion so hard. I guess this is something that we must to observe, like aggression. Is another kind of aggression. Maybe a little hidden because it's not physical, but it's aggression too. What I can say about all these things about my fellows are in the same way of thinking. They are like me, like others, tired. We are really sad. We are in the line of the sickness, mental sickness. And we really need the authorities doing a lot of work to get this to a better way to work. Dignity, with dignity, not having to get a really big mass of people doing something to, hey, please look at us. This is not good. This is aggressive too. This is aggression too. Thank you so much. Thank you, Rebecca.
So yeah, no, thank you, Aileen, for sharing your experiences and just kind of actually telling us what it's like. You know, it's very easy to see those numbers on the map and hear about these stories, but it's definitely different hearing it from yourself firsthand. So thank you. And you obviously, you mentioned governments and the healthcare facilities themselves. And Len, I want to ask you, do you have recommendations for governments, for healthcare workers, for the health facilities themselves on how they can do better, and how might this map also feed into that in terms of protecting and safeguarding healthcare workers?
Thank you, Rebecca, and thanks to all the panelists. I can't get, now I can start my video. I couldn't start it a moment ago. I want to first thank all the panelists for their really illuminating and very moving accounts, because they show the pain of what's going on, not just from this terrible pandemic, but how people on the front lines are suffering from it. I'd like to, before getting to recommendations, I want to provide another perspective on the issue in the larger context of the violence and how we can think about this. We need to do a lot more. We need a lot more understanding of what the evidence shows about what is driving these attacks. But we've known for a long time that there are two kind of separate phenomena going on. One is that workplace violence, as our speakers have said, is pervasive in routine health practice. It's often generated as a result of patients' or families' unhappiness with the care a patient has received. And it's very common. My own institution, Johns Hopkins, some years ago, a doctor was shot in the hospital by a man upset over his mother's care. This happens all over the world. Another form of violence against health workers comes in war or during political crises. That violence usually has a political dimension. Perpetrators want to gain a military advantage, or they want to hurt people seen as enemies, or they want to punish doctors for treating enemies or political protesters. COVID-related violence seems to have elements of each. It is directed at health providers doing their jobs in their workplaces in a non-political way, and seems to occur without any apparent political overlay. It appears, as the speakers have said, motivated a lot by fear of infection, concern about the impact of restrictions on movement and livelihood. But it does have a political dimension in many cases, not all cases, but in many cases. It's stimulated by disinformation promoted by people with a political agenda. It can result, too, from a long history of distrust of the health system, in part because of inequities in those systems. And so there is a kind of protest element. So we have to see these problems on a continuum of personal fear and anger on the one hand, and political on the other hand. And we saw this in the Ebola outbreak in the Eastern Democratic Republic of Congo. There had been an armed conflict going on there for a long time, though much of the violence against Ebola responders came from community members or so-called self-defense group. There's a lot of evidence now that the violence was stimulated by distrust of a government that people felt had failed to serve their health needs, and corruption was rampant, politicians spread disinformation, and communities were treated as objects, not partners. I think that's why when we think about what the response to the violence in the context of COVID-19, we have to address, of course, increased security for health workers, but also the political factors and the structural factors, as some other speakers have mentioned, that tend or seem to stimulate the violence. This requires political leadership, honest, consistent messages about the pandemic, serious engagement with communities in addressing both the outbreak and sources of underlying distrust and feelings legitimately of inequity. And most of all, though we haven't talked about this a lot today, the response must not include repression against those who challenge government policies. So we have to work on these different levels to address the fears, the feelings, the sense of loss, the grievance, the grieving, as well as the political responses toward prevention and, of course, accountability for the perpetrators. I'll stop there so that we can open the floor to questions.
Great, thank you. And yeah, we've had a couple of questions come in, and I would say to anybody that's watching who still has a question they want to put to one of our panelists or all of them, do feel free to put it in the chat box. We'll do our best to get to it. And I would encourage our speakers to kind of be as concise as you can, just so that we can get through quite a few. But our first question is from Christina, and it is around what extent has social media played a role, if at all, in the increase of insecurity for healthcare workers and providers in 2020?
I think it was very significant. It's extremely difficult to pinpoint it down to something very specific, because we never know how many people are looking at social media, who has read what, and all of this. But whenever we've looked into individual cases, there does seem to be very often a social media influence there. And social media can be everything from people reinforcing their views to actually inciting violence or justifying the violence against health workers. So I think it's a really important question, because I think we need to look more at social media to understand how this also contributes to violence and threats of violence against health workers.
Great, thank you. And Erica, we've had a question come in for you. You touched upon the indirect causes in terms of attacks on healthcare workers, and somebody would like to know whether or not you've had any positive experienced any positive impact when you've recruited and trained female nurses and midwives locally and within the communities that they're then going on to serve.
Yeah, definitely the pandemic has not been only negative stories. We've seen communities stand out in the evening to applaud the work of nurses. We've certainly seen communities come together knowing that, there are over 27 million nurses. Nurses are part of communities. And so I think we've certainly seen a lot of support, especially considering 2020 when the COVID-19 came about, was the International Year of the Nurse and the Midwife. We have had this sort of spotlight and this recognition and this increased support for the work of nurses. We are looking at how this pandemic has impacted the nursing profession across many different issues. One of them being this desire of people to help, and how do they do that? And so we have had some countries reporting an increase in enrollment to nursing programs. And so this is, this makes us extremely happy, considering what we've just talked about and the risk of these deficits that we face. So it hasn't all been doom and gloom. Certainly we've seen this dedication and commitment and nursing profession as a way to be leaders in your community and leaders for global health. And so that has been sort of a positive outcome of this spotlight on nurses during the pandemic.
Great. Well, yeah, that's good to hear that it's not all so doom and gloom. Our next question is around the role of national or international level scientific and medical organizations and how they can be useful. Lynn, I don't know if that's one that you would like to answer.
Well, as you heard, the International Council of Nurses has been very active in drawing attention to these problems, as has the World Medical Association and other medical organizations. Domestically, I think at the national level, some have been much more active than others. I think in general, there's a lot more they could do. We haven't talked about solidarity, and solidarity is so important that people on the front lines know that their peers around the world are supporting them, they're speaking out for them, and even when they can't do anything for them, particularly concretely, just knowing of their support makes a huge difference. So I would urge that medical and nursing and other health groups become even more active. They've been very focused, of course, on how to respond to the pandemic, and they have their hands full, but they have to support people, not only in their own countries, but throughout the world, in order to raise the visibility and provide the needed support.
Great, thank you. And George, what are your thoughts on this? Do you think there is a role that such organizations can play, and what kind of support would actually be helpful to you in the work that you do on a day-to-day basis?
In India, outside of COVID, during COVID, I think the main problem for the violence was because of the fear of the virus, and people were really frightened that the healthcare workers were spreading the virus, as Erica said, and that was not helped by the messages which was coming out from the World Health Organization, where they said, that every day you would get a new scientific paper. So I can't really agree that it was misinformation. There were so many scientific papers. There was one which said that people would get infected with aerosols hang in the air for a long time. So the normal person was afraid of healthcare workers. And this led to them not being willing to be approached by them. So I think that, you know, the scientific information also has, has some role in having caused the violence this time. But in India, outside of COVID, the main problem why there is violence is because of a mistrust of doctors, which arise of healthcare personnel, especially doctors, because of the unequal access to healthcare in India. In a very highly privatized system, with a very large number of our people under a poverty line of $1 per day, having such a highly expensive and privatized system makes people believe that you will get good care only if you have money. And so when a person dies, even if the death was inevitable, there is a feeling that if they had more money, they would have been saved. And this is sometimes taken out as anger against the frontline worker. And I'm sorry to say that we as doctors have no training of how to handle grief. It's coming in now, but you know, at the time I was trained and up to very recently, it is very difficult for us to handle the patient after they have lost a loved one. And this is usually the cause of violence because of perceived neglect or not doing enough because of lack of money. So unless we address structural inequalities in India, so the healthcare international organizations, in my opinion, should look at what are the healthcare, I mean, what are the causes of violence in each country. So in India, it is due to inequitable access. I'm very sure about this. It may be different in different countries. So I don't know. I don't know what the situation, what is the situation for violence in the United States or in the UK. But in India, it is inequitable access.
Thank you. Yeah, I think that's a really interesting point that you make, that, you know, it might not be a one size, well, it certainly won't be a one size fits all approach, and recommendations and solutions will have to be tailored to each individual context. Alina, I want to come to you and ask about anything that any recommendations that you have, anything you feel that international organizations, governments, and healthcare facilities themselves should be doing to better protect you as you work and do the great work that you do.
Well, Rebecca, I guess this is a lot of work to do with our governments in the collaboration with all these institutions, like the Council of Nurses, but also is a theme really, really hard too, because here in Mexico, almost the money, like George said, the most of the money was for the political situations. And we need to have an investment in health, in personnel, in preparation for the health personnel. But it's really a too much work to do here, and we need maybe more work from the government in the collaboration of the others institutions globally. I guess we need that.
Great, thank you. And George, we've just had another question come in for you, speaking of government action, around whether or not there's been any evidence of a decrease of incidents, attacks and threats for healthcare workers after the ordinance to strengthen the legislation to protect healthcare workers by the Indian government was passed last year.
In my opinion, it made no difference. There have been many laws, but they don't work as a deterrent because the problem is something else.
Great, thank you. Before we end quickly, I would like to come to each of you and ask if it's not laws, what else is it? Do you have a call to action? Is there something that our audience can go away to and do today to kind of help tackle this issue? And Christina, we'll start with you first.
Well, I guess my call to action is a little predictable. I like everyone who has information on violence against healthcare to share that and to make it more widely known that we all together can develop a much better picture of what goes on. So if anyone would like to share further information, please do get in touch and we'd be delighted to work with you and include your experiences in what we are mapping.
Great, thank you. And Erica, what about yourself?
I'll just briefly describe the top three. So the first thing I would say is support for healthcare workers, free, confidential mental health and psychosocial support services being available. Now that's at the end of the line, and of course we want to work at higher up as well, upstream. And so definitely systematic data collection, data on the incidence of violence, and then disaggregated by type of attack, the gender of the victim, the profession of both the victim and the gender of the perpetrator and the victim, and then investment in these systems so that they're stronger and that we're having accurate and more data. This is the only way that we're going to be able to create policies that will help protect health workers is with data that then translates into practice. And then the third thing would just be an increased recognition of the impact of this issue. It's so great to hear from George, to hear from Alin, who are on the front line, who are experiencing this. I think we need to humanize these, coupled with the dots on the map and the personal stories. I think it really shows us why we need to act, and governments need to be aware of this, as do the public, to stop this. So this would be my sort of top three: support, data, and recognition of the issue.
Great, thank you. And thank you for mentioning the need for the general public to know as well. I know oftentimes we kind of turn into an echo chamber in the sector internally, so that's a very important point. George, what about yourself?
I would say that in India, actually, doctors and healthcare personnel are generally held in very high regard. So in the short term, I think what would help us in the short term is being able to learn communication skills. The usual problem in India for violence against a doctor is because of poor communication of a serious event. So that's a short-term thing. But the long-term, and what we really need, and which will probably be the most important cause for reducing violence against medical personnel, healthcare personnel in India, is equitable access, for which we need massive government investment. No government they have been saying it over and over again, but unless we have it, it's not going to happen. This continuing violence will be there because people perceive that they are not being taken care of.
Great points, thank you. Alin, what's your take?
Like George said, we need investment in this kind of situations to be prepared to this kind of situations. We know that nobody knows before about this kind of virus, and in the history of the humanity, this kind of situations has happened before in other disease. But I can't believe we're still not ready. We're still not ready. In the history, is not the first time. And it hit us once and again and again and again. We must be better prepared for this. And we must be clear in the situation that the health personnel are working. We are working without resources. We are working without personnel. And this is difficulting the situation in the aggressions too, because the people doesn't know that we are trying to help. This is what we are doing. We are trying to help. We are not trying to get sick other people's. need to investment to the knowledge of all the people.
Right. Yeah, thank you. I think it's really important to underline that healthcare workers are just trying to help, as you say. So thank you for really bringing that message home. And Len, over to you. What are your thoughts?
I think one of the things we've learned from this discussion is how, on the one hand, context is crucial. India is different from Mexico, and we have to respond to the situation in the country with great knowledge of the country. But I also think there are some kind of overarching themes that have come out. One is we must address the structural issues, whether it's deprivation of the rights of women or inequitable access to health care that kind of feeds or ends up magnifying fear and likelihood of violence. A second thing is in the response itself. Protection and prevention of violence has to be as much a priority in pandemic response as getting vaccines or other aspects of the response in place. Third is there has to be attention to security. In the short term, security is absolutely essential. It's the only thing that can help, that people have to be safe in their workplaces. And fourth, we have to pay attention to the perpetrators. Even if there are a lot of drivers, these perpetrators must be held to account. They can't be engaging in violence with impunity. So I think we have to work on all those different levels. And it's the fact that we do shows how difficult the problem is and kind of what the road ahead has to, the roads we have to take, not a single road.
Great, thank you. And thank you to all of our wonderful panelists. It's great to have some actual action items that people can take forward and really start implementing and thinking about. Unfortunately, that is all we've got time for today. I know many of us could probably keep having this conversation for a lot longer. And I would encourage you to do so online. And as Christina said, the tool, the map, is meant to be interactive and evolving. So please do share your information and get in touch with the team. The website, the email address, it's all in the chat box at the side. But yes, thank you so much for joining today, for joining in our discussion. It's obviously a very important topic, and it's been great to hear so many different perspectives. So yeah, thank you all so much. And once again, thank you to our panelists. Have a great rest of the day.